We are ready.
Good afternoon, everyone. I'd like to thank you each for participating in our first Virginia Department of Health Project ECHO COVID-19 Tele-ECHO Clinic. Some quick disclaimers. Next slide. VDH is rapidly working to develop resources to address COVID-19. Our guidance changes and all participants are encouraged to continue their own research. If you have a question, please email ivp@vdh.virginia.gov and we'll have a timely follow-up response. Next slide, please. This session does count toward continuing education credits. VNA has approved 1 hour CNE and Carilian's Clinic CME program designates this as 1 AMA PRA Category 1 credit. All speakers have no conflict of interest, and following this session, VDH will post the didactic, links, information, and the evaluation link, and instructions for receiving education units at VDH's Project ECHO website. Closed captioning is offered for this session. Next slide, please. This Tele-ECHO Clinic didactic is used for educational purposes. By participating, people are consenting to being recorded, and recordings will be posted on projectechosbox.com, protected by password. Clinicians can view this recording later at their leisure, and materials will be shared with the Project ECHO community. Please mute yourself when not speaking, and please do not share any information that identifies or can be linked to a patient's identity. Next slide, please. Our facilitator today is Dr. Stephanie Greasy-Williams. Dr. Greasy-Williams is a board-certified pediatrician with experience in both emergency rooms and urgent cares, as well as 6 years at the CDC's Center for Preparedness and Response. Dr. Greasy-Williams is currently working diligently with VDH to help with COVID-19 response. Our VDH consultants are Diane Woolard and Carol Jamerson. Diane Woolard is the former director of VDH's Division of Surveillance and Investigation, who came out of retirement to help VDH on the COVID-19 response. Carol Jamerson is a nurse epidemiologist with VDH's Healthcare Associated Infections and Antimicrobial Resistance Program, and is an infection preventionist with 25 years of experience and board certification in infection prevention and control. Our clinical consultant is Dr. Colin Wozencraft, trained in internal medicine palliative in Richmond, Virginia, before practicing and teaching nationally and internationally, focusing on implementing palliative medicine in developing regions. Thankfully, he now lives again in Richmond and has retired from clinical practice, but continues to have an interest in medical education, ethics, and economics. Our speaker today is Dr. Amy Mathers. Dr. Mathers is the Associate Professor of Medicine and Pathology at the University of Virginia School of Medicine. She serves as the Medical Director of Antimicrobial Stewardship and Associate Director of Clinical Microbiology. And with that, I'd like to turn it over to Dr. Greasy-Williams.
Thank you, Hector. Can you hear me?
Yes.
Perfect. So good afternoon, everyone. As always, I'll start by briefly reviewing Virginia's case counts and our epidemic curve. The information on both of these slides can be found on the Virginia Department of Health COVID homepage, and the maps on that page are also interactive if you'd like to delve a little deeper into the data. As of yesterday, Virginia has 52,177 total cases with 1,514 deaths. As the heat map shows, Northern Virginia, the Richmond metro area, and Southeastern Virginia continue to be the areas accounting for the highest number of total cases. Next slide, please. This slide shows our epidemic curve, which is the number of cases by date of symptom onset, with the yellow line showing a 7-day moving average. As you can see, we have been seeing a pretty consistent decrease in case counts, although the caveat that illness occurring in the past 14 days may not have been reported yet, and it may not be reflected on this slide, still applies, although it is good news that we're seeing a little bit of a decrease. Next slide, please. Today's clinic topics will be testing for primary care providers. We know this is a really hot topic right now, especially with the increasing availability of serology tests, but also the number of questions surrounding diagnostic testing. And so I anticipate this will be a really great session today. We will not have a case presentation this week, and that's so that we can answer all of the questions that were submitted from participants before the session. We want to make sure we have time to answer all of those. And as always, after reviewing this session, if you have further questions, we do have an email address that will show at the end where you can email any further questions. and we will send those answers out to all participants. Next slide, please. So with that, I'd like to welcome Dr. Mathers. We're very excited to have her here with us today to present this information. And Nick, if you don't mind switching to her slide set. Perfect. And Dr. Mathers, I'm going to turn it over to you.
Thank you so much. And thank you so much for the invitation. So hopefully we can just go through some nuts and bolts of testing. And I will say that I focused largely on diagnostic testing, molecular-based testing, because I think it's such a moving target. And when people talk about we need to increase testing, they're really talking about diagnostic testing. However, I will finish with a brief mention around serology and where that's at, and can take questions about kind of any of it. So go ahead, next slide. I have no disclosures to this topic. And then next slide, please. So if you live in the United States right now, you know that testing is a huge issue for coronavirus control. And it's pretty much consensus in the United States that the way that we're going to open up our economy and get back to some semblance of not having to all physical distance, we're going to need to increase testing. And BDH has put together a great strategy around, aggressive testing strategies and then testing paired with contact tracing to really limit large spread outbreaks and increase case counts. And so central to all of that is the availability of testing. I think it's important to look back on where we've come. I mean, just, it's kind of crazy that it's only been 3 months really since this started, and less than that since UVA did its first test for us, and actually just before that, before DCLS or the central lab. So we're 3 months into this, and I think that it's good. This is a great time to just check in about where we're at. When we first started, there was such a constriction on test availability. We really had to, out of necessity, focus on the most important people to test. So the sickest patients, patients in the hospital. But as we open up this strategy around testing to control the pandemic, I think it's going to be really important, and this is such a great opportunity to engage primary care doctors for how we're going to work together to help do that and help support patients around the state. And primary care doctors are going to be central to that mission. However, the logistics around massive testing for an infectious disease are not trivial, both in terms of lab reporting, collection, shipment, all of those things. It's a big lift for all of us. And so I think that's kind of what I'll just get through today. Next slide. So on that note, here's the updated criteria from BDH as of this week. And what I've done there is in sort of dark blue is all the patient groups that are symptomatic testing priorities. And so you can see there that the Department of Health has nicely put in sort of what they're hoping private and commercial lab testing will be focused on versus where are those gaps and how is public health testing going to be directed. And so you can see there in the baby blue or light blue, all the people that are going to need to be tested that don't have symptoms. And so again, the contact tracing, public health surveillance, point prevalence, all of those are going to be important missions for the Virginia Department of Health. And that leaves sort of the primary care doctors and others to identify cases, especially based on symptoms, or potentially in other areas. So the places where we're going to be testing non-symptomatic patients in the primary care realm is people that are close contacts in support of sort of trying to eliminate transmission, and or those that your hospital's asking you to make sure that they don't have coronavirus because they're going to undergo some high-risk infection control issue like a surgical procedure. Otherwise, we should still be focused on symptoms. But the issue here is that when we originally started, we were focusing on symptoms in the most vulnerable and that was the direction and guidance given to primary care doctors. But I think any symptoms, you think they have COVID, a fever, a sore throat, a cough, go ahead and test them, because we need to increase testing. And I think the greatest value of testing coronavirus for diagnostics is in the symptomatic population, because you can say with some confidence, and that's what the rest of this talk is going to be devoted to, that that person does or does not have coronavirus to explain the symptoms that they have on that day. And so for me as a physician, that is the greatest value of a test. And I'll talk a little bit more about that. Next slide. I think it's just important. I figured I'd put this up. This is University of Virginia's guidance around who we're testing right now. And this might mirror, and I only put this up for reference, just that you can see the majority of people that we're testing are symptomatic. We are still not testing anybody who wants a test and doesn't have symptoms. We just don't have unending capacity. And so we really need to focus our resources. Next slide. I think the goal here, and it's important, you don't need to track this as a primary care physician, but just so you have situational awareness, the goal of the state is to be testing enough patients and capturing enough positives that we stay around or below the 10% positive per test rate. And so that means that we're not totally reliant, because as we expand testing, of course, we're going to find more positives, which is what we want to do, but we want to make sure that we're doing enough tests so that we don't, so there's a balance between making sure we're testing enough and making sure that we're finding the positives. So that's sort of the goal. And this was the first week since the outbreak, since the pandemic began, that we met a 10% goal. And today it's actually at 9% positivity per test run. Next slide. So this is the question that I wanted to answer for you guys with today's talk. What's the sensitivity of the SARS-CoV-2 diagnostic test? And I think it's really important, and if I get nothing else across, we don't know. So I'm sorry to say that I don't have a better answer for that, but there's a whole host of reasons why we're not 100% sure. And I think that what I'd like to do is give a better framework for how to think about the positive and negative impact of a SARS-CoV test in an individual patient. Most of what I'm going to talk about is symptomatic patients, because we have so little data on asymptomatic patients. It's very difficult to know what the sensitivity is in that patient population, because we have no data almost. But I'm gonna just talk about some of the ways that I think about what's the sensitivity in an individual patient. And that means, how much can I rely on a negative test to tell somebody, go ahead, go back to work? Of course, again, we're trying to get everybody to wear masks and do things that stop the spread of the virus. And so I think that will help. But, you know, telling somebody they're free of disease is a little bit of a nuanced mission. The things that impact the sensitivity of the test are multiple fold. So first off, the coronavirus, and I'll talk a little bit about this, replicates at different rates in different spots. The timing of the disease, when did symptoms start, and where are you testing that patient? When were they in contact with somebody that had the virus, and when are you testing them? What is their age? I think we're learning a lot about that. And then the degree, character of their symptoms, and there's likely other factors that we're frankly not completely aware of. Next slide. So, one thing that has muddied the waters and made this extremely confusing for the average primary care doc is that there's been complete variability in the molecular lab. So there are now 74, as of this weekend, cleared diagnostic tests through the FDA. Keeping in mind that usually for these tests in normal business, you would have to actually have a complete FDA packet where you had people that had proven disease, suspected disease, and that your assay actually paired with other elements in a large population to detect the people with symptoms and with disease to say that your test worked. We have none of that. Most of these tests made it to market with very little data, and basically it was contrived specimens. You could take an MP swab, spike it with known virus, run it on the thing and say, okay, it has this sensitivity. So just remember that most of these platforms did not have much actual clinical, most of them have no clinical data in their FDA packet. So what's happened is a lot of them have gotten to the micro lab with, or even out into the field with that kind of variability. And some of them have not performed. And so there's a couple of rapid diagnostics where buyer beware, and the FDA has now had to file a claim that if you use that diagnostic and you get a negative result, you actually need to back it up with a positive, more sensitive molecular assay. And it's really important to remember that, because hopefully in the state of Virginia, we're not going to have 25, 30% positivity of everybody that walks through the door at any point. And that's really the only time those kind of less sensitive tests are valuable. And so I can just say that the antigen test, I get a lot of questions about, sort of a swab and then a stick, like a strep test, not performing with enough sensitivity that you don't have to back it up. And also the Abbott ID Now came out with an FDA warning that you need to back up all negative tests. And that's the one that you can kind of do on site. All of the assays that we've adopted and that most bona fide molecular labs, including the commercial labs, have adopted have a viral sensitivity around about 100 copies per mil. And so that's a pretty sensitive test. And so you can be confident that if you're sending it off to DCLS or sending it off to your own lab or LabCorp, you can be pretty confident that the test is working fairly well. Just watch out for that Abbott ID Now, because they are deployed in some labs. Next slide. So briefly, I just want to touch on coronavirus itself. So this is not actual real data, but it's a really helpful figure from a Nature paper that sort of shows one of the problems with coronavirus. And so in that top bar, the blue bar is incubation period and no symptoms. And so you get exposed to virus and you don't have any symptoms. And if you look over on the other side, they've got an example of SARS, the 2003 SARS virus, coronavirus, or seasonal influenza. And what you'll note is that asymptomatic period is very short, and nobody's making any virus or shedding virus in that time period. And then looking to the the COVID-19 side of the slide, which is those three bars, that's one of the problems. You start shedding virus before you know you're shedding virus, which is why universal masking is going to be one of our most critical tools for stopping spread. And it varies somewhere. And so there's different models about how much you're shedding before you're actually developing symptoms. But we know that it's a fair bit. And we think potentially 12% of transmissions occurring in that pre-symptomatic phase. Next slide. This is some really nice data that kind of starts to get to usable data for the primary care doc. So this is actual data, and they took all the studies looking at coronavirus, and it's a meta-analysis, so keep in mind it's only as good as its weakest study. But looking at time of exposure being day 0. And there at the top is the likelihood that you're going to have a false negative. So it's a little bit of an inverse table, but at day 0, if somebody gave me coronavirus, coughed all over my face, and I got coronavirus, it adhered to my ACE2 receptor, I know on day 1, I'm not going to have a positive test. You have to have viral replication for there to be a positive test. Day 2, still going to have a negative test. And it's by day 3, even before I have symptoms, because that line going down is when symptoms start. Day 3, pre-symptoms, you have about a 25% detection rate. So 75% sort of false negative, if you will. And by day 5, which is the day of symptom onset, it's about a 60% detection rate. And then a couple of days after that, it gets even better, down to like, only 20% false negative rates, and then starts to wane. And so you can see there that, first off, no test is perfect. And I'm just going to talk about how to try to mitigate the sensitivity. But if you think about your pretest probability and your likelihood of whether or not this person has coronavirus and has symptoms and all of those things, that's going to need to be accounted for when you get back a negative test, and how you're going to assess that patient and then give them advice. Next slide. I just put this up as a reminder to let you know that, location really matters. And so there's been a lot of, not misinformation, but a lot of different information as we've learned about this virus of where it is. And I can tell you, just in summary, it's not in the blood, it's not in the urine. There is detectable RNA at high level in the stool, but there's very little viable virus. And this was a study just looking at several patients and took multiple samples from them on, I think it was 20 patients, multiple samples from them on various days, showing kind of what their viral carriage rate is, or RNA detection rate from different body sites. Next slide. What we also know is early on in symptomatic patients, they have a lot of virus in the beginning of this infection. And it's probably part of why it's so contagious and giving us such a hard time. There is an incredible amount, and in this one study, they didn't have a single negative in that first 5 days around symptoms. And so if somebody just had new onset fever and they come into you and they had exposure to coronavirus, that test is frequently positive, and there's frequently a lot of virus circulating at that point. Problem is the viral replication does fall off after 5 days. And the viral detection, the RNA detected in the upper respiratory tract, does fall off after 5 days. And that's a lot of the time when you're seeing people that actually have the complications of coronavirus. So remember that if somebody had a fever 7 days ago and they're presenting to your clinic or calling you because they're having a hard time breathing or their SATs have dropped, there is not often as much virus at that point, 7 to 10 days after, even though that's when they're getting sick, because we know that that's a lot of times when the immune system's kicking in, and that's what a lot of the complications that are hospitalizing patients and causing the mortality. It's probably coming from some interplay with the virus and the immune system. The other thing to remember is, so we don't talk much about coronavirus specificity in testing. However, people are detectable for long periods of time. This is a study showing hospitalization, and they have detected virus in patients' upper airways for as far out as 37 days. I think we just broke our record and had a 41-day from the time that their first coronavirus was detected until we were detecting virus late. So it stays positive for a long time, at least in hospitalized patients, which is where most of this data comes from. Next slide. So what about where you get it? So, okay, Amy, well, I'm a primary care doc. Should I use a throat swab, a nose swab, spit? What should we be doing? Well, we're not 100% sure, but I would say nasopharyngeal swab is the most sensitive. It's across multiple studies that's kind of fallen out as the most sensitive. The top chart is just 14 symptomatic patients. And throat came out better than nasal, which nasopharyngeal is different than this study. And then this other study came out this weekend in the New England Journal, and they looked at 450 patients. 52 had a positive test by some mechanism. And they compared self-collection with a healthcare collected nasopharyngeal swab. And you can see there that self-collected tongue, you missed some. Not too bad though. I mean, if you're just looking sensitivity, self-collected nasal and self-collected mid-turbinate. There, the bar charts are sort of showing the CT values. They were lower in the tongue than they were in the paired nasopharyngeal. So you can see the decrease in sensitivity for each one of those mid-turbinate self-collect or nasal self-collect techniques. And so what I want to start having you wrap your head around is there's a bunch of things that can happen that can lower your sensitivity of an already imperfect test. And so if we start adding in, oh, let's just spit into a cup and send that off, and we're using a lousy platform and they're latent infection, at some point you don't have a test that works for much at all. And so anything you can do to mitigate some of the differences in sensitivity, like specimen collection, platform performance, please try to do it. And that's in a time of constricted resources. So it's hard to do. Next slide. Children, I just wanted to make a mention of this, but what we're finding out is sort of this asymptomatic stuff and what's going on with kids. I think we're starting to get to the bottom of some of it. So children, unlike that last slide where I showed, or 2 slides ago where I showed, viral carriage out to 21 days. So here is children, 10 hospitalized children, none had pneumonia because it's very infrequent that they get severe coronavirus infections. But these were kids that were hospitalized and had COVID, and you can see there was nobody positive at day 21. They just don't have as much virus. And what also came out about 10 days ago is a nice study showing that children have fewer ACE receptors in their nasal passageway, and those increase with age. So it makes sense, virus binds to those ACE2 inhibitor or ACE2 receptors and starts multiplying in your airway. Well, if you don't have any, maybe the virus can't adhere and start multiplying. Next. So ultimately, it's going to vary with age is my point. And potentially symptoms and contagiousness is going to vary with age. So in summary, there was a really nice piece in the New England Journal, a commentary of sort of what are the challenges. And what I want to say is the thing that you can kind of control is what was your pretest probability? You got somebody who lives in a household with people diagnosed with coronavirus, and they're coming to you or calling you about a fever. I would say that's a really high pretest probability that that fever may be driven by coronavirus or SARS-CoV-2. And I would say that's like an 80% probability. So if I get that test back and it's negative, I don't think I'm going to believe it, at 90% sensitivity. I'm going to say that could be wrong. And that's a 90% sensitivity. I think our tests in that scenario might be slightly more sensitive than that. But again, where'd you collect the specimen? All those things that we just talked about. And so, to consider somebody not infected, you've really got to keep your wits about you. If you have a much lower threshold, like somebody just has been self-isolating at home, no real exposure, they have a fever and some other alternate explanation, that's a really low pretest probability. You can probably rely on the negative results. So I think there's a lot to be considered here. And you do really want a good test, and you want to try to mitigate all the factors you possibly can control to make sure your test is working well. Because at some point, if the test doesn't perform, it's actually not helpful. It's somewhat misleading. So, and then I'm just going to finish with logistics for primary care physicians and a last slide on serology. So I can go through these real quick and then I'll take questions. So I do want to point out, again, this is a contagious, high burden virus, infectious disease. And it's contagious to the people that collect the specimen. And it's also contagious potentially to lab people that are handling it. So it does need to be handled, even though we're talking about massive thousands of people tested every day. We got to be careful, and we got to keep ourselves and our healthcare staff and our lab partners all safe while all this is going on. So first off, you need to get the swab and you need to get the viral transport media. Those two also can impact sensitivity. You've got to make sure you can get it to the lab in a timely fashion. While you're collecting this nasopharyngeal swab, you need to have the right PPE in your office and the resources to protect your healthcare staff to get it collected safely. Getting it to the lab, and then we can run the test, and that's pretty easy, but then getting the results back and making sure you call all those folks and give them advice about positive and negatives. So there's a lot of steps, and when we're talking about this massive testing efforts, even if you've got patients and you're not running these tests, just know that a lot of people are getting into the game that have never gotten in the game before, and some of these little arrows are broken a bit, so, or maybe crooked. They're not totally broken. So next slide. So this is just to show you sort of, lots and lots of virus. The nasopharyngeal flock swabs are the most sensitive. They release it. The wrapped ones hold on to virus a little bit better. So if you can get nasopharyngeal flock swabs, that's great. If you can only do oropharyngeal, it's pretty good. Release it into a viral transport media, and then make sure you can refrigerate it after and just safety and collection, eye shield, contact precautions, and a N95 mask during collection. Next slide. I always advise people to label the specimen in advance because you don't want to be doing all this once you're sort of in the room and doing everything for somebody you highly suspect of coronavirus. Once you've collected the specimen, you break the tip off into the viral transport media tube, wipe it down with bleach wipe. Luckily, disinfectants work really well to kill coronavirus, including alcohol, bleach. Most disinfection works really well. Put in the specimen bag with a lid that's on tight, and then you need to wipe that bag down because it potentially has virus on it, and you're thinking of your lab staff so they don't get contaminated, and then you put it in another bag. So category B requires 2 bags, actually requires 3, and then you put it in the refrigerator, ultimately for a courier to pick up to take to the lab in a 3rd container. Next. And this just sort of shows you the outline of kind of how to get it down, how to dispose of it. Making sure you stay safe and you collect it safe and package it safe. And then last slide, or next slide. And again, here's just some details on the shipping and how to do it. It is important once you've collected the specimen to get it refrigerated because other bacteria and things will start multiplying and they may negate the ability to find that coronavirus RNA. And last, I think I just touch on serology. Yeah, and then just trying to remind you to keep our lab people safe because, contaminated bags, they're opening not in a hood. They're receiving these, our couriers. We want to make sure nobody gets coronavirus in the process of collection. Okay, and then if you can't handle all this in your clinic and do any testing in your clinic or can't find swabs or any of these issues, and here I've kind of put together a checklist of the things you would need to do testing, coronavirus testing in your own lab. Some labs have been doing, or some clinics have been doing something where they don't want to do PPE and bring that person into their clinic, into the waiting room that has potential coronavirus. So doing a call ahead, have a nurse run out to the car in PPE, collect a quick coronavirus specimen at the curb, package it up and do all that so they're not having to clear a room to get it collected. If none of this is possible for you, there's a map that VDH has put together where all the places that can do coronavirus testing, including CVS and multiple other places, are doing it, and you can send your patients there. Most insurances are covering coronavirus testing, even kind of in the asymptomatics, it's pretty much covered. All right, and I'll finish with just one slide on serology. Oh, sorry, keep wanting to talk about serology, but the last thing that you should know is turnaround time is variable. So the testing platforms, the molecular platforms, take anywhere from 13 minutes to 8 hours batched. So that means it's really a 24-hour turnaround time. I know that if you're sending to a commercial lab, the average turnaround times that I'm hearing verbally are like 3 to 4 days at this point with LabCorp and Quest and some of the larger commercial vendors. And so you should prepare your patients to not hear back right away. Through us, through the state, we're trying to stay to a 24-hour turnaround time, but really even by the time you call somebody back, it's closer to a 36 or 48 hour that they should expect results. We have developed sort of what do you say to somebody when you're calling them with their coronavirus results. And there's some great resources available on CDC about sort of how to go through we suspected you of coronavirus, you tested positive or negative, and talking them through it. And that's where the clinicians are going to be really important in understanding what the pretest probability of that test was to begin with. And then once positive, the duration of contagion that's sort of being officially advised is, 3 days with no fever and symptoms have improved and 10 days since their first symptom appeared. So when people are saying, when can I come out of home quarantine? That's pretty much the standard advice right now. Next slide. Serology. So I didn't spend much time on serology because I think it more important even than the diagnostic testing we do not have any paired clinical data about what serology means. What I will say is worse than the diagnostic tests, initially there were 90 companies that had developed and claimed a coronavirus serology testing claim. The FDA originally did not get involved and we're just going to kind of let these out the door. But because it was becoming so confusing for patients and everyone, they got in the game and they basically have approved several platforms, and it's updated on the FDA website, about 10, 11, it's probably more now, FDA cleared platforms. It's important to remember that these tests were not even cleared with any viral inhibition assay paired with them, meaning it may match patients that actually had a SARS-CoV-2 infection and developed antibodies to it, but we don't know if those antibodies are protective. We don't know if those antibodies are durable. And so I think it's really important to advise patients that although serology is available and it's fairly accurate for telling people they had a SARS-CoV-2 infection, we're not sure what that means in terms of their safety for not getting a second infection or their protection for any subsequent problems. And so the last thing to consider is that and this is the assay that we happen to be using, and this is pretty much what's been shown, is in the data that is available for these FDA cleared tests, which is really slim, there were 4 false positives. So if you're testing 1,000 patients in the state of Virginia and we've only had a 2% positivity coronavirus infection rate, you know, somewhere on the order of a quarter to a third of your positives are going to be false positives. And so that is another reason why I'm not a fan of mass serology testing in a really low prevalence community, you know, population. And so, yeah, that test performance actually looks pretty good, 99.6, that's decent, but because of the situation that we've got such low conversion rates, it does make it harder to interpret. Last slide. So just in conclusion, I think testing is going to be critical. Partnership with primary care physicians is going to be critical. I think there's more known now than there was a month ago or a month before that about testing performance, but we've still got a long ways to go. Sensitivity of diagnostic coronavirus testing depends on a lot of different factors, and I think I've just touched on some of them. Collecting a coronavirus, running a coronavirus can take several steps and can prove to be difficult logistically, and there are some resources available to get patients to a coronavirus test if you can't do it in your own clinic. I struggle with exactly what to do with serology at this point. I think we'll know what to do with it more soon. The one caveat I meant to mention on my slide was the only place I've seen a use for it is in hospitalized pediatric patients who have a potential for the post-coronavirus inflammatory condition. If they've got a good clinical picture for that, we do send serology straight away, and if that's positive, that helps us diagnostically. So with that, I'll take any questions, and I went over time, and I apologize.
All right, well, thank you so much, Dr. Mathers. If we could go to the next slide, that'd be great. Thank you. So I know a lot of people submitted questions beforehand, so we have those questions that we'd like to go over. If time permits after that, I know I have a few questions. I don't know if Dr. Wozencraft, who I know is on the line, if he has questions, but let's start with the questions that were submitted beforehand. Some of them may have been covered in your slides, and if that's the case, we can probably just do a brief answer. And then after that, if Dr. Wozencraft has questions, and then if there's still time after that, then I'll ask mine. But Hector, I think you're going to go through those questions, so I'll turn it over to you.
All right, thank you, Dr. Greasy Williams, and thank you, Dr. Mathers, again for the presentation. I think that the information was incredibly valuable and well delivered. So we do have a few questions. Starting out, can you share some myths surrounding COVID-19 testing, and how have you had to work with patients and families to address those myths?
Yeah, I think myths, I think, is a important word. I think there's misconceptions might be the better. And I think the biggest misconception I come across most frequently is that we could just test our way out of this thing, and that we need to be testing lots and lots of asymptomatic folks. I'm with very low risk of exposure. I am completely on board with we need to test people in terms of contact tracing and finding symptomatic patients and testing those aggressively, and then trying to find where that virus is spread. But remember, virus doesn't come from nowhere. It does come from another human being. And so people that are really, really low risk and have been able to physically distance probably don't have coronavirus. If they have symptoms, very, very valuable to test them, because you can say the symptoms you have are or are not related to coronavirus at that time with some confidence, especially if it's early on in infection and close to the time they have the fever, because we know that you really don't start to see that lowering of sensitivity until later. But the idea that we need to do these, test everyone all the time, I just don't think that makes sense. I think we need to come up with some really thoughtful ways to target finding patients in the population that are positive. And I think that's one of the bigger myths that I've sort of heard that. And I guess the other one that comes up, and it may not be from individual families, but it's kind of work related, these ideas that you can test everybody right at the beginning of opening your business and make sure you start with a clean population, or maybe we should test everybody right before school starts, and so we could prove that they were clean. That's a fool's errand, only because you saw that right after you're exposed, you've got virus, but it's 2 to 3 days before you're detectable. And so I just worry that you could actually sort of falsely label a population as virus-free, bring everybody together, maybe even into a congregate setting, and sleep well. There is going to be an important paired testing risk factor strategy involved, but I think that you could just sort of forget about the risk factors, forget about everything else, and just test your way out of it is, I think, a big myth. And so that's what I would say. And I think the last myth that's been a little frustrating is anybody can get a test at any time they want to test. And not quoting anybody, but I just think that wasn't true then, and it's not completely true now. I think that's not helpful. We need to be testing the right people at the right time, and everybody getting a test whenever they feel like it's probably not helpful to anybody, including the person getting the test.
Thank you for that. And then building on that response, what would you suggest are the best communication strategies for healthcare providers to discuss that prioritization of testing with patients and families?
Yeah, so I think that's really important. And what I would suggest to primary care, because again, this has been an evolving situation. And I know I personally told people, yeah, I think you have coronavirus, but you can self-isolate and I don't have enough tests. Just stay home. And that's not the strategy we should use anymore. So it's really important that we communicate with our patients a shift in strategy. We need to test symptomatic people whenever the opportunity arises. And so I would make sure to communicate with your patients if they feel like they have symptoms that they think could be attributed to the coronavirus, especially as we open up the state and there's more physical interactions between people. We need to understand transmission. And there probably will be some more transmission. We're hoping not, if we can test around and keep the spread down. But that strategy means that we're aggressively testing symptomatic patients. So if somebody calls you and says, I have a sore throat and I was wondering if this is coronavirus, you should test them if you can, or refer them to a testing center. And so that is a big shift that should be conveyed with families.
And is there any kind of specific fund statewide that helps cover testing for everyone, or including those that don't have insurance?
Yeah, so testing should be free to anyone who needs testing. So symptomatic patients will get tests covered. I don't know all of the logistics around places like CVS, but if you reach out to your health department locally, if the clinic can't do it, if you reach out to your health department locally, or if you go to that VDH website with the map, it does have details about what kind of insurance, or if they're covering, or if they'll give tests to uninsured. So uninsured folks should be able to find a place to get testing done when they're symptomatic. So look on the map, call your health department, and or look for community events. Those are always free and sponsored by the state. Well, not always, but the ones that I've been involved in have been.
All right, and what are point prevalence surveys, and does it involve testing staff and residents in congregate settings?
Yeah. So point prevalence, so it's important to go back again to the beginning, and Virginia early on and aggressively put in social distancing orders from Governor Northam early days. And those worked really well. I have no doubt in my mind that those saved thousands of lives in the state of Virginia. The issue is there's groups of places where you can't socially distance or physically distance. Congregate living, Department of Corrections facilities, some types of work, essential worker locations. And so that's where we saw a lot of transmission occurring. And it's especially devastating in the nursing home population because, as everybody knows, the elderly have the highest mortality from this infection. And that's who's largely living in nursing facilities or nursing homes. And so to respond to that strategy, the Virginia Department of Health started doing point prevalence surveys in some of those facilities to understand how transmission was occurring and try to separate out positives from negatives within a facility to try to manage ongoing transmission or forward-going transmission. And so, interestingly, it's called a point prevalence survey, but it's actually more like a try to figure out who's positive and who's negative at any given point in time, which sounds like a point prevalence survey, but usually you don't respond immediately to point prevalence surveys. And so they were sort of a hybrid of an epidemiologic tool plus a kind of public health interventional tool. And it's important that you test not just the people that live in the congregate living situation, but that you also test all of the staff. Because again, the virus doesn't come from nowhere, it comes from somewhere. And so if you've got a nursing facility and no visitors are allowed and nobody's allowed to go in or out, really the virus comes in because it was acquired by probably the healthcare workers who don't live there and live in the community. And so it's been really important to be proactive about trying to understand any unseen transmission as it goes through a congregate setting, because it's very hard to control the spread in that setting, unlike people who can social distance. And so I hope that kind of answers the question. These are going to be ongoing, and Virginia has committed to getting through every nursing facility in the state, as I understand it. I'm not employed by VDH, but I work with them. And so, and I think that's, we're here to support that.
Thank you so much. And I'd like to go ahead and turn it over to Dr. Greasy Williams.
The last thing, Hector, as she's getting up and running, I will say about point prevalence is it is the place where you test symptomatic and asymptomatic. You test every single person in the facility at a point in time. And what I will say is in a lot of those instances, especially in the elderly, what we've caught or captured with those is pre-symptomatic patients, which are probably quite different than people that are asymptomatic and have just asymptomatic carriage for a period of time.
Got it. Great. Thank you, Dr. Mathers. Dr. Wozencraft, did you have any questions for Dr. Mathers?
No, not at this time. However, thank you very much. Excellent presentation. Much appreciated.
Great. Hopefully it helps.
Great. Thank you. And then I just had a few questions, and then we'll kind of wrap it up at this point. And I think you touched on this already, but I just want to make sure I'm clear. But you know, the FDA has started approving some rapid tests in addition to kind of the more traditional diagnostic tests. And so I was wondering if you might briefly review the pros and cons of which test to use in a primary care office. And if you are using a rapid test, do you then need to follow up kind of with a more traditional test if it's negative?
Yeah, I think this is a real difficult issue, because ideally in a primary care office, you would have a rapid test like a strep test or a flu test. And there is a rapid test that's been approved, an antigen test for diagnosis of SARS-CoV-2. The problem is that the sensitivity is such that you have to back up all negatives with an additional test, as I understand it. And I know more about the rapid molecular test, the Abbott ID Now, than I do but that was my understanding of the antigen test, that because of the performance and you knew you would miss a fair number of positive cases, that you need to back up all negatives. And the problem is for example, at University of Virginia, our positivity rate has been solidly at 8%. And so in a place where if we were New York City, mid-late March or early April, an antigen test would actually be really helpful, right? Because you'd have positives. The problem is like, if you've only got an 8% positivity rate or a 10% positivity rate, which is kind of what our state goal is, it means that, if you do 100 tests and you've got a 70%, you're going to be sending out, 2 missed positives and plus the 95 real negatives for additional molecular testing. So you might have caught, a few positives, and that's helpful. But you got to do a lot of negative tests. And so then you've got to really weigh the risk benefit of having that. And unfortunately, that is the best place to have it, or in the OR. I hear this all the time. Can't we just use a rapid test in the OR? And you're like, well, except that, I'm getting all this. There was a lot of move to do a lot of pre-op testing of kind of everybody. So there was so people felt like, patients were for sure didn't have COVID before surgery. And, I'm hearing, I just got a message this morning actually from another hospital system where they've done 3,000 tests and found 7 positives among the asymptomatic carriage rate. And so it's just, and that's with a very sensitive test. And then lastly, I'll finish with the Abbott ID Now. It's that box that looks about yay big. The one other caveat that I'm going to add to the Abbott ID Now and why I'm not a big fan of putting that in a doctor's office is because there's some infection control risks that make me a little nervous about having that in your office. Because you've got virus sitting on a swab, you take a dry swab and you put it in and you have to vortex it around, and the solution that you're mixing it around in does kill the virus, but it just makes me very nervous to do that in an office repeatedly, and the amount of contamination that I have envisioned. Most labs that have adopted it or hospitals that have brought it in, they actually have the instrument in a hood where they do that. So. Oh, I think you're muted.
I am. Thank you. I just said that would make me a little nervous as well.
Yeah.
So it sounds like, you know, when we think about rapid tests for coronavirus, it's very similar to flu, where the prevalence in the community has a very high impact on how likely the test is to be positive or negative, as opposed to our strep tests with the reflex PCR, where we can use those year round. So that's actually very helpful. And I think I have time to ask one more quick question. And I know that I think the answer to this has been discussed in the news and media, but for those hospitalized patients where you were finding, you know, SARS-CoV-2 out at the 37, 40-day point, do you know whether or not that was a viable virus or infectious virus?
You know, I suspect it is not viable or infectious virus. The problem is like a lot of those patients where we're taking it all the way out to 40 days is because they need to go back to the nursing home. And so to put somebody in a naive elderly population with a positive test is awkward. And so I don't think they have viable virus. There is some data out showing that there's not much detection of viable virus beyond 10 days. The data is small. I think that's what's going to come out. CDC is doing a large study. We're contributing isolates about, you know, people that were tested serially to see when viable virus is no longer recoverable. I suspect that it's probably contagious for 10-ish days. The one caveat to that, though, is, you know, with things like influenza, in immunocompromised patients, you can see influenza viable virus with prolonged shedding in those folks. And again, we don't know who those people are. And so it just makes everybody very, very nervous to put them into a naive population. I send people home with positive detectable RNA and with a home isolation plan with a fair bit of confidence. It's just nerve-wracking to send them back to a nursing home.
Great, thank you so much. And I found this presentation to be very informative and very timely as well, because I know at the Department of Health, we've been getting a lot of questions about this. So thank you so much for doing that.
Yeah.
And if we could move on to the next slide real quick. For those who are watching this recorded session, if you have additional questions for Dr. Mathers or for the Virginia Department of Health, we do encourage you to email us those questions. You can see the email address here on the screen. We will compile those questions and answer them. We usually have both our speakers and our clinical consultants and our VDH consultants review those answers, and then we send them out to all participants. So you will receive that summary of questions and answers after we answer them. We try to get that sent out before the next session. Doesn't always happen, but we do attempt that. So please email us your additional questions and we'd be happy to answer them. If we could go to the next slide. Great. And then we like to end with just a few suggested key resources based on the topic. We have a couple of different websites on here from the Virginia Department of Health. We've just revamped our testing website, and so there's some great information on here. In particular, the third link, the Testing, Laboratory, and Therapeutics link, that is specifically for healthcare professionals, so you can find some very good information there. We also have the CDC and FDA websites up here, including the website where they summarize the serology test performance. And I only mention that because we are getting a lot of questions about serology. Although, as Dr. Mathers emphasized, diagnostic testing is the most important at this point. And I believe that is it for me. Hector, anything you want to summarize at the end before we close? I think we're right on time.
Nothing additional. Again, I'd just like to thank Dr. Mathers for the amazing presentation, and for everyone participating and watching. Thank you.
Thank you.
Thank you, everyone. Oh, actually, we do have one more slide. I'm sorry. You can go to the next slide. Okay, so we'll just end with a reminder for what our next session is. So next Thursday from 12 to 1, we'll be recording our next session, and it will be available thereafter. And we'll be covering 3 different special populations, obstetric patients, children, and dentistry. And the registration link can be found at the Project Echo website. So that is it. Thank you so much, everyone, and have a great day.
Thanks.